Hello everyone, this is Dr. Sandeep Sharma here, and let us now discuss the important topic of short stature in children. Short stature refers to chota height, but short stature, what parents perceive and what pediatricians perceive, they may or may not correlate with each other. Short stature may sometimes be self-limited, as you see in patients of constitutional delay in growth, or it may be really troublesome, really problematic, producing dwarf children, as you find in some of the severe hormone deficiencies. So we need to discuss this topic inside out. Super specialty entrance, you often find detailed questions being asked from this topic, so we'll discuss in all aspects. So let us begin the discussion. First of all, what is the definition of short stature? Definition of short stature is based upon a parameter called as height for age. So the definition says any child who is having height for age below third centile is said to have short stature. Or second definition says height for age in a child below -2 standard deviation of the population mean, then we will call it as short stature. Why there are two definitions? Because if you look at the growth charts, there are two types of charts which are available. One, charts are based upon centiles. In centile, you will have 97th, 50th, 10th and 3rd centile. So when you plot on that chart, and if the age related height of the child is below the 3rd centile curve, then we call it as short stature. On the other hand, if you have a standard deviation or z-score based chart like those of WHO, and you plot, and if it comes below -2 standard deviation curve, then also we call it as short stature. So two types of definition exist based upon which chart you are using. So simply by looking at the child, you cannot say this child is having short stature. You need to take height of the child and plot on one of these charts. Let me show you a picture of these charts and how questions can be asked in exam. So you may get a chart like this. This is the first type of chart. It is pink in color. Usually WHO uses a color code in which blue stands for male charts and pink stands for female charts, although not all organizations follow this rule, but it is a girl's chart, height for age. It is a one based upon centile. If you see on the right side, you have the centile curves mentioned. You have the 97th centile at the top and the 3rd centile at the bottom. Suppose you have a 12-year-old child coming and the height of the child is 120 centimeter. So parents say our child is not growing, he is very short as compared to other children. The child's age is 12 years. So what you will do is, we'll take a gender appropriate chart. If it is a girl child, we'll use a pink chart, right? On that 12, this is the, on the x-axis you have age here. So look at what is the age in years, it is 12. Right? On the y-axis you have height. So you have taken the height, it is coming to be 120 centimeters. So you will plot it here. This is where it is lying. Now it is lying below the 3rd centile. So what is your definition? What is your diagnosis? The diagnosis in this patient is short stature. So this is the example of first type of chart if you have this chart in front of you. So you may get a visual in super specialty where they will say a child was brought to OPD and the chart is showing height of the child is plotted on the chart shown below. What is the diagnosis? If it is plotted and it is below 3rd centile in this chart, it will be short stature. If it is above 3rd centile, it will not be called as short stature. The second example, the second chart which you need to know is this chart. As you can see, it is based upon standard deviations or the z-score curves. You have the mean value, you have +1, +2, +3 standard deviation, -1, -2, -3 standard deviation, also called as z-scores. So you have, if you plot on this curve and suppose there is another child, 10-year-old child, and you plot and it comes between -1 and -2, you will not call it as short stature. So this is not a short stature child. If it is below -2, then you call it as short stature. If it is below -3, then also you call it as short stature. Obviously, it will be the more severe form. So any child in this chart, if you plot the height and it comes to below -2 standard deviation, you will call it as short stature. So interpretation, definition is one thing, interpretation in visuals is also equally important. So first is definition, height for age below third percentile or height for age below -2 standard deviation. Next we come to the types and causes of short stature. There are many ways you can classify, but the most popular one is you divide it into physiological and pathological short stature. So broadly speaking, there are two categories. You have physiological short stature, in which there is no underlying disease, and second is pathological short stature, where there is an underlying cause, underlying disease which is responsible. So physiological short stature, how do we say it is physiological or pathological? Remember, physiological short stature, they will have a normal growth velocity. Growth velocity is also called as height velocity, whereas pathological short stature will have decreased growth velocity. This is a very useful point, potential MCQ, but students often miss even in super specialty. Now what do I mean by growth velocity? It's as simple as the name sounds. I have a child coming to me for the first time. Parents say height is not growing. I take his measurement, I plot on the chart, it is below -2 standard deviation. So I prescribe a few tests and I ask them to improve the nutritional status and ask them to come after 6 months. Now 6 months later child comes, I again plot on the same curve. I find that the child has gained 1 centimeter in those 6 months. Then I look at what a normal child of same age gains. Suppose a normal child of same age gains 1 centimeter and this child has also gained 1 centimeter. So I will say the child has short stature but his growth is normal. So we will call it as normal growth velocity. Past mein something might have happened which led to short stature, but right now his growth velocity is normal. We call it as physiological short stature. Physiological short stature has a good outcome, and when you plot on the chart, these children tend to run parallel to the growth curve. They don't cross it, they don't fall below it, they just run parallel to the growth curve. So physiological short stature, they have normal growth velocity. There are two causes or two types of physiological short stature. The first one is the most common variety, called as constitutional delay in growth, and the second form is familial short stature. Details of all these individual causes, the important causes, we will be discussing separately. Abhi we are just summarizing all. Now we have pathological short stature where the growth velocity is less. So second scenario, child comes to me, I plot after 6 months, normal child has gained 1 centimeter, this child has not gained at all in 6 months, or normal child has gained 2 centimeter and this child is gaining only 0.2 centimeter. So I will say there is decreased growth velocity with short stature. Pathological short stature is the answer. What are the common causes? There is a huge list. We'll restrict it to the important ones. First is nutritional causes. For example, protein energy malnutrition. According to Nelson as well as textbook of pediatrics by Dr. Suraj Gupte, it is the most common pathological cause of short stature. Right? Constitutional delay in growth is the most common overall cause of short stature. Remember this. So overall sabse puche constitutional delay in growth. If they ask most common pathological, it is nutritional cause. Second, it can be due to chronic diseases. Chronic diseases, again very common cause of pathological short stature. There can be multiple chronic diseases which can cause short stature in children. For example, you may have cystic fibrosis. The child may be having severe asthma. There may be malabsorptive symptoms like celiac disease. The child may be having problems like congenital heart diseases, etc. There is a huge list you can write. You can be as creative as you want. Thirdly, it can occur due to endocrine disorders. Among endocrine disorders, there are three which are important. First is hypothyroidism. Second is growth hormone deficiency. And thirdly, it can occur due to Cushing syndrome. Then it can occur due to syndromes, common syndromes like Down syndrome, Turner syndrome, Prader-Willi syndrome have been found to be associated with short stature, pathological short stature in children. It can occur due to skeletal dysplasias like achondroplasia, which is one of the commonest causes of short stature. It can occur due to IUGR. IUGR can produce a type of short stature, what we call as primordial dwarfism. It can also occur due to psychosocial factors, poverty, child abuse, and overcrowding. All these factors can cause short stature. So this is the broad list of physiological and pathological short stature that you need to remember from entrance exam point of view. Other than this etiological classification and the types, the short stature can also be divided based upon the body proportions. So we have types of short stature based upon body proportions. I have told you in one of the previous modules about the upper segment to lower segment ratio. You know that upper segment is the sitting height from top of head to midpoint of pubic symphysis, that is upper segment, and below that is your lower segment. And the ratio begins as 1.7 to 1.9 ratio 1 at birth and becomes 1:1 somewhere around 8 to 10 years of age. This is something you already know. So types of short stature based upon body proportion can be divided into two parts. There can be proportionate short stature and there can be disproportionate short stature. In proportionate short stature, the upper segment to lower segment ratio is appropriate for age. Whereas in disproportionate, the upper segment to lower segment obviously is not appropriate for age. The causes of proportionate short stature, the common causes, they include conditions like constitutional delay in growth, familial short stature. So all physiological short statures are proportionate. It includes nutritional short statures like malnutrition. It includes conditions like nutritional, in bracket you will write, except rickets. Rickets does not cause proportionate short stature. Fourth, it occurs in growth hormone deficiency. And fifth, you will find that these children, chronic illness children, are found to have proportionate short stature. Then we have the disproportionate short stature. Disproportionate can be of further two varieties. Disproportionate can have short limbed short stature and short trunk short stature. In short limbed short stature, remember that the upper segment to lower segment ratio will be greater than expected. Greater than expected means at a certain age, say normal child was having 1.3 ratio 1, but this child is having 1.8 ratio 1. So this is more than expected. That will be producing short limbed short stature, whereas short trunk will have upper segment to lower segment ratio less than expected for age. What are the important causes here? Short limbed short stature is commonly seen in patients with rickets. It is also seen in untreated congenital hypothyroidism, especially congenital untreated hypothyroidism. It can occur in achondroplasia. It can occur in Turner syndrome. Whereas short trunk short stature, that can be seen in mucopolysaccharidosis. There is a type of mucopolysaccharidosis called as Morquio disease. It occurs in mucolipidosis. It occurs in vertebral anomalies like hemivertebrae, tuberculosis of the spine or Caries spine, and it occurs in spondyloepiphyseal dysplasias. So these are the common causes of proportionate versus disproportionate, and among disproportionate, short-limbed versus short trunk, short stature. Now there is a very interesting thing mentioned in some of the textbooks. If you go by O.P. Ghai, it says that rickets is a cause of short-limbed short stature, right? But there are other textbooks, including textbook of pediatrics by Dr. Suraj Gupte and two of the nutritional texts plus one review article. They all say that some children rickets can also produce short trunked short stature. So remember that rickets, if you have to choose one, it causes short limb short stature, but it can, in some patients, it can also cause short trunk short stature. So this can produce depending upon whether the central axis is involved or the peripheral limbs are more involved. So you can have either type of disproportionate short stature in patients with rickets. Growth hormone deficiency usually has a proportionate short stature. This is your NEET super specialty MCQ already asked some years back. Please mention it as one of the one-liners. So this is the second classification of types of short stature. Next we move to the clues to underlying etiology. History में ऐसे कौन से point हैं? What are the points which will tell you that this could be the likely possibility? If on history you find the patient is having steatorrhea, that is bulky, foul-smelling, sticky stools, or there is a chronic diarrhea in the patient, you will think of malabsorption, for example, celiac disease as the likely possibility. If the history says that there is low socioeconomic status, there is overcrowding, alcoholism, poor spacing between the childbirth, you will take a history, it will be poor socioeconomic status, father, mother are laborers, 7 children in the family, everybody, 7 children and both the parents staying in a very small hut. So you can think of the child not getting attention, not getting nutrient, and the growth not happening. Psychosocial dwarfism will be the likely one of the differential diagnosis. If on history you find that there was low birth weight, the child's birth history, you will take, they will say the child was born with weight of only 1.5 kilograms. So you will think of small for gestational age baby, and you will think a possibility of primordial dwarfism. Then if the patient is having lethargy, weight gain and coarse skin, hypothyroidism will be one of the likely possibilities. If the history says poor appetite, all these are key words. If you get a clinical case, you need to keep them in mind. If the question says poor appetite, low socioeconomic status, then protein energy malnutrition needs to be considered. And if there are headache, vomiting and visual changes happening in the patient, then you will think of CNS lesion. It may be craniopharyngiomas or some pituitary tumors which may be related with panhypopituitarism and growth hormone deficiency. So these are the clues for underlying etiology when you take history. Similarly, when you check examination findings, certain examination finding will give you a clue for the underlying diagnosis. So delayed puberty in parents, always think of constitutional delay in growth. Clues to underlying etiology on examination. If you do check for pallor, you need to rule out anemia and chronic kidney disease in the patient. Dysmorphism, if it is present, you think of syndromic causes. In case the patient is having frontal bossing, crowded teeth, depressed nasal bridge and small penis in males, you will think of a pituitary cause, especially growth hormone deficiency. In case of disproportionate short stature, you will think of causes as described, short-limbed and short trunk short stature. And finally, if the patient is having central obesity and thin extremities along with hypertension, you will think of Cushing syndrome as the likely possibility. So these are the clues for underlying reason on examination. Now, a very important thing, concept of chronological age, bone age and height age when you evaluate these children. So let us try to understand what these ages are and what is their significance. So the first thing is chronological age, that is, I'll write in short as CA, bone age, also called as skeletal age, BA, and height age, that is HA. So what is chronological age of the child? The actual age of the child according to date of birth is chronological age, right? So I'm just writing here, chronological age refers to the actual age of the child. What is bone age? I have already defined in one of the other modules, but I'll repeat it here. Bone age is it is an indicator of skeletal maturity as determined by X-ray of the bones. So what we do is we take X-ray of the bone, we look, depending upon what age different bones can be used, you look at the number of ossification center, then you take the help of charts and you calculate the age based upon X-ray. It is not the actual age, it is the age based upon X-ray of the child. So that is an indicator of skeletal maturity. And third is your height age. Height age is, first I'll write the definition, then I'll explain with an example. Height age is the age at which the present height of a child is normally attained in a normal child. Confusing? I know. Let me give an example. You are sitting in an OPD, a child comes to you. Parents say our child is not growing. Okay, he is a 6-year-old child. So what is 6 year? So you will take a form and mention chronological age 6 year. That is the actual age of the child, right? Then you will order an X-ray. X-ray kahan ka karenge? You know that in this child, 1 to 12-year child, it is the hand and wrist X-rays which are important. So you will get an X-ray of the hand and wrist, both hand and wrist, you will get it done. Once the X-ray comes, you look at the number of ossification centers by using Grulich and Pyle method or Tanner's method. You will find out the age based upon X-ray. Whatever age comes out, that will be bone age. Suppose chronological age is 6 year, right? And bone age comes out to be 5 year. So you will write bone age 5 year based upon X-ray, right? It is not the actual age, it is the based upon X-ray. What is height age? You will take the measurement of that child, actual height, right? Actual height. Now suppose you have taken actual height, and actual height in this child is 100 centimeter, right? Now 100 centimeter is normally attained in a normal child at what age? You know that it is attained, if you can take the help of a growth chart also. 100 centimeter in a normal child is attained at 4 years of age. So what is the height age of this child? 4 years. What it means is, it is not the actual age of this child. The age at which present height is normally attained in a normal child. That is the height age. So why are we calculating these three confusing ages? Because the correlation between them gives us a clue for the underlying diagnosis. The most important among them, which is a first line investigation, is bone age, which gives us a lot of clues. So what is the interpretation that you need to remember? The first interpretation, I'm dividing it into two parts. Any short stature child, in any short stature child, chronological age exceeds bone age or height age or both, right? अगर सब कुछ correlate होगा, if everything is correlating with each other, there will be no short stature. So in any short stature, chronological age always exceeds either bone age or height age or both. Second thing, whenever bone age exceeds the height age, the overall or ultimate height, the adult height, will be less. Whenever height age is equal to or more than bone age, the ultimate height will be better. Adult height will be better. What is the meaning of this? End of the day, you have to mug up, but try to understand. Suppose there is a patient, this child, right? The example I gave you. 6-year-old child, chronological age, bone age came to be 5 year, and height age, because of 100 centimeter height in this child, it came out to be 4 years. So bone age is exceeding the height age. So if bone age exceeds height age, it means bones are maturing early as compared to the height of the child. If bones are maturing early, the epiphyseal growth plate will close early, and so the overall height will be less. In case height age is more than bone age, what will happen? The bone age is, the skeletal is immature. Growth plate is still open. If you treat the cause, later on growth potential is still present and child can catch up for the gap which happened. So ultimate height will be better. Remember, bone age more than height age, growth plate closes early, less adult height. Height age more than bone age or corresponding to bone age, ultimate height will always be better if you treat the underlying cause. So they help you in prognostication when you sit in growth clinics or in pediatric endocrinology clinics. And third scenario, you need to remember about the important parameters in various etiologies of short stature. What happens in various forms? I am giving the heading to remember. This you will have to mug up. There is no shortcut here. In case of constitutional delay in growth, the chronological age exceeds the bone age as well as height age, right? But bone age and height age are parallel. In patients with familial short stature, chronological age corresponds to bone age, but both of them exceed the height age. So, short stature, chronological age ज़्यादा होना चाहिए, either bone age या height age से, so both are having short stature, right? But if I ask you, which will have a ultimate adult height better? The answer is constitutional delay in growth. Why? Because in familial short stature, as you can see, the bone age is exceeding the height age and so the ultimate height is less. For prognosis, you only look at correlation between bone and height age. You don't talk about chronological age. Thirdly, in endocrinological causes, especially hypothyroidism, you will find untreated cases, obviously. Chronological age is more than height age and bone age, but height age is sometimes exceeding the bone age. Very rarely you may find them to be correlating as well. So we are putting a star like this. So these are the three important correlations that you need to remember. Can be asked in exam, have been asked in exam. So I'm putting a big SS here, super specialty MCQ. If I am an examiner, you do hope I am not your examiner because I'm very fond of putting atypical questions, but any examiner of yours, he or she will put one of these as super specialty MCQ. It is the hot topic, it is a difficult topic, not properly understood at MD level at many places. So this is the concept of chronological age, bone age and height age. In this form, it has not been explained in most cases, but if you understand it well, I have gone slow. You can rewind this video, see again. In case you still have problem, you are most welcome to ask me on the discussion forums and put mails and elaborate about it. We have put questions based upon these in the question bank also, but get the concept right. This is one of the rank decided questions, difficult questions if it is asked in exam. So moving from the concept of chronological age, bone age and height age, before we go further, let us try to see if you get a visual upon this, how you are going to solve, right? This is the flow chart given to you. Now, I will show you three types of curves and you have to look at it and tell me the likely diagnosis. How are we going to do it? See, the first chart, the first plotting, a child came to you, the question will come something like this. A child comes to you in OPD and was followed up for many years. His heights as plotted on the curve are shown below. What is the likely diagnosis? So first is green colored child. I am putting it like this. Right? You try to plot it. I am plotting this green colored child. So this is getting plotted like this. Okay. Second child. He is plotted like this. I am using a different red colored pen. I plot it. So it is getting plotted like this. The third child, I am using a blue pen. This child came. Okay. So now tell me the diagnosis in all the three varieties. Now many of you will be perplexed, sir, how can we tell the diagnosis from this? You can. First of all, in childhood, all the three cases, the growth curve, the plotting is below -2 standard deviation. So the answer is short stature, right? First step, look if it is in the childhood below third centile or below -2 standard deviation. It is a -2 standard deviation curve. So below -2 means it is short stature, right? So short stature to hai. Look at the first child. First child, it is the green colored child. It was below -2, even below -3 centile at the beginning also, remained below third centile, below -3 standard deviation throughout the childhood, and the curve was always parallel to the other growth curves. So if something is parallel to the growth curve, it indicates, so 3 is having, so this green colored child is having physiological short stature, right? Look at the red colored child. Here also, except for the fag end, throughout the childhood, it is running parallel to the growth curve. So this is also having a physiological short stature. Now we know that there are only two types of physiological short stature: familial and constitutional, right? Constitutional ultimate height is less. So this one, can you see that during adulthood, it crossed beyond standard -2 standard deviation. There is a late spurt which came. So this will be your constitutional delay in growth, whereas familial short stature will be all throughout short in the childhood, at birth, and even at adulthood. So this is your familial short stature. We always say familial short stature children: mummy short, papa short, baby short. Born short, remain short, die short. That is familial short stature, right? All in the family, but all of them short. Constitutional delay in growth. They are born normally, as you can see, the red colored child, right? Born normally or just below -2 standard deviation. Birth ka hame pata nahi, because birth probably it was not done. Then around 6 months to 1 year of age, they become shorter. Then again, they run parallel to the growth curve, and as age advances, they have a late growth spurt somewhere around 15-16 years of age and rapidly gain height to become normal in the adulthood. So born normal, become short, but die normal. That is the saying we say for constitutional delay in growth. Now look at this blue colored dots. This child was normal till here. normal till here. Then the growth started faltering like this and it become plateaued. Whenever growth becomes plateaued, it is not parallel to the growth curve. We always call it as pathological short stature. We always call it as pathological short stature. So to summarize, how to identify on a growth chart. This is on a growth chart which I have shown, right? To simplify, I'm making a handmade diagram for your visual MCQs. So if I make a handmade diagram, and this is your growth curve, starting from, say I am taking a birth to 18 years. So this is your birth chart. This is your 18 years, right? We only look at the third centile or the -2 standard deviation curve. Either third centile hoga or -2 standard deviation curve. That is what we are supposed to look at. If it is plotted parallel to the curve and remains below the curve only, you call it as familial short stature. If it is parallel to the curve but near 18 years, it crosses, around 15-16 years, it crosses the third centile and short stature does not remain so, then we call it as constitutional delay in growth. And if you have a plotting becoming plateaued, not following the growth curve, becoming plateaued like this, or severely retarded, below -3, below -4, sometimes just not growing at all, just becoming static like a straight line, think of pathological short stature. These are the things you need to remember if you get a difficult visual based question in your super specialty exam. Very similar questions for practice have been added in your question bank. Next we come to investigations. In investigations for short stature, the level 1 investigations are also called as essential investigation. Any child with height below third centile or below -2 Z score has to be to undergo these investigation. So these include the following investigation. First, you have complete hemogram with ESR, urine analysis to look for any underlying UTI or chronic kidney disease, stool analysis for any worm manifestation or stool for fat globules in case of malabsorption that you will look for. X-ray has to be done for bone age calculation. I've told you that bone age has to be calculated in all children. Renal function test, calcium and phosphate level. Sometimes alkaline phosphatase is also included in it. And finally, serum albumin, fasting blood glucose and transaminases to look for any liver disease, chronic disease we will perform. So this is the level 1 investigation. Second, we have the level 2 investigation. In level 2 investigation, we will perform thyroid function test and karyotyping to look for any syndromes, particularly Turner or related aneuploidies. Third, we have level 3 investigation which are needed as a third line investigation, which includes serology for celiac disease. You will do TTGA test, anti-endomycin antibody. You will do growth hormone provocation test, IGF-1, IGF binding protein 3 levels, and you will, if needed, if indicated, you will do MRI brain. Contrary to popular perception, growth hormone deficiency is a rare cause of short stature, and so it is not considered to be either first line or second line investigation unless you have a strong reason to look for it. So, and this is what these investigations also show. Now moving towards approach to etiological workup. This is very, very important from MCQ scenario point of view. You may get MCQ scenarios based upon this. So let us try to understand how you proceed. Any patient who comes to you with short stature, so child with short stature comes to you, you categorize into two forms. In case the growth velocity is normal and the height for age is between -2 to -3 Z score or -2 to -3 standard deviation, usually you will think of physiological short stature. In case the patient is having chronological age more than bone age, you will think of, and bone age equal to height age, you will think of constitutional delay in growth. In case chronological age is equal to bone age, but and both of them are in front of height age, you will think of familial short stature, right? In case the growth velocity is low, and the height for age is less than minus 3 z score, severe form, the so-called dwarfism, then you will think of pathological short stature. In patients with pathological short stature, in case the patient is having any dysmorphism or altered upper segment to lower segment ratio, think of syndromes, think of related conditions as we have discussed in the list we have already formed. In case they are not present, normal facies, normal, no dysmorphism present, normal facies, normal upper segment to lower segment ratios. In these patients, you will first perform level 1 investigation. Then you will perform level 2 investigations. जो पहले हो गए, वो you will not repeat them, and then you will do level 3 investigations. And if level 3 investigations have been done and nothing is coming out, you think of idiopathic short stature, you can consider growth hormone therapy. You can give a trial of growth hormone therapy in case nothing is coming out of it. So this is the etiological workup which has been simplified. Similar flowcharts with minor variations are mentioned in various textbooks. So from entrance point of view, I have combined them, compacted them and given it in a form, will be easy for you to remember. Now let us talk about the growth hormone stimulation test, which was the third line investigation, but questions have been asked on this in the medicine part, in the endocrinology DM part. So super specialty, you may get, there is sometimes overlap between the things, and so you may get some random question in one subject moving over there. And it is a part of the general pediatrics, so we have to anyways discuss a few points related to it. So growth hormone stimulation test. In this, they are also called as growth hormone provocation test. The common provocative agents used, earlier we used to go in for exercise based regimes also, but they are difficult to do in children. So we go in for pharmacological agents like insulin, glucagon, clonidine or growth hormone releasing hormone. If after giving these provocative agent, if peak growth hormone level is less than 10 nanogram per ml, this is a potential MCQ, then you should suspect growth hormone deficiency. And if it is present with clinically significant short stature, then you treat on the lines of growth hormone deficiency. Other than this, what all you can do, you can also go in for IGF-1 levels, insulin-like growth factor 1 level, and insulin-like growth factor binding protein 3. They are helpful to diagnose GHD as well as differentiate it from Laron syndrome, in which these IGF-1 levels may be altered. Now, let us discuss some points, one-liners related to each of the individual causes of short stature that we have discussed so far. First is your constitutional delay in growth. What are the points about it from entrance that you should know? It is the overall most common cause of short stature in children, right? Hota kya hai isme? What exactly happens? These children, they are normal at birth, but they grow normally till around 6 to 12 months of age. First birthday tak they grow normally, but between 1 to 3 years, for a variable period of time due to unknown reasons, they have slowdown of growth. They have a slowdown of growth, which leads to them developing short stature. By the time they come to medical attention, again growth resumes. And so, when you check, they are found to have a normal growth velocity. But this gap which had come in this 1 to 3 year, that persists, and so the child runs parallel to the growth curve but not crossing the third centile, not crossing the -2 standard deviation curve. Why it happens, we do not know. It is a very frequent cause. Uh, in some of the populations, the percentage of the prevalence of constitutional delay in growth is as high as 4 to 5% in the general population. But the good news is these children, they have a relatively better outcome. Constitutional delay in growth has a few other problems also happening. Constitutional means DNA, genes mein hai. The child is supposed to have this kind of delayed growth pattern. In constitutional delay in growth, what are the things other than this that you will find? They will have delayed onset of puberty, which is a very useful clue. And they will, because puberty is delayed, so they will have a delayed pubertal growth spurt. Normal pubertal growth spurt comes around 12, 13, 14 years. They will have pubertal growth spurt as late as 15 or 16 years. But once puberty comes, once spurt comes, they rapidly gain height. And most of them have a better adult height, which is above -2 standard deviation. So they tend to lie above -2 standard deviation. Some of them even catch up to have a normal height of 5'7", 5'8", 5'10", 5'12", that is 6 feet. That has also been known to occur, although it is much less common in the Indian context. What it means is, if I have to give you a scenario, constitutional delay in growth, we do not know the reason. In constitutional delay in growth, the child is born normally. Till 1 year, 1.5 year max, the child will grow normally. Between 1 to 3 years, the child will stop growing. 3 years of age, parents will notice our child is not growing as compared to similar children. They will take him to the doctor. The doctor will do all the tests, everything will come out to be fine. Chronological bone age, height age correlation will be different, as I have already told you. You can write it here. They will have chronological age more than bone age will be corresponding to height age. This is the pattern you will find. Doctor will ask them to come after 6 months. Growth velocity will be found to be normal. These children, because they are having short stature, they will develop stigma. They'll go to school, they will be called names, their puberty will be delayed, pubertal growth spurt will be delayed, but they do take their revenge. If you like revenge stories, this is one revenge story which has a good ending. So once these children, gangs of Wasipur, Faisal badla lega, Faisal takes his revenge. If you have watched that movie, you will correlate with it. So when does Faisal take revenge? In the second half. That is, once pubertal growth spurt begins, these child rapidly gain height and they tend to become normal. It is so common, you might have seen some variants even in your own personal life. You were in 9th standard, or your cousin was in 9th standard, 10th standard, very short, suddenly went to summer vacation, came back, now tall. And you are like looking at him, what happened to you? He would say, I had constitutional delay in growth, my growth spurt came late. So they usually have a good ending. They do not have short stature, many of them, by the time they reach adulthood. What is the one-liner that you need to remember, which is mentioned in Nelson 21st edition? The serum IGF-1 levels are low for chronological age, but normal for bone age and height age. So this is one MCQ one-liner that you need to remember. This is constitutional delay in growth. Next is familial short stature. I've already told you. Father short, mummy short, baby short. Born short, remain short, die short. So familial short stature, they are found to have borderline low birth weight and length, and they have decreased or slow growth in infancy as well. They were growing normally in infancy. Here, the Chronological age corresponds to bone age, but both of them are in front of height age. They have normal time of puberty as well as normal time of pubertal growth spurt. Their overall adult height is less but appropriate for target height. Remember, there is a formula called as target height according to height of parents. According to height of parents. So there is a formula I have told you in one of the module, mean parental height, father's height plus mother's height divided by 2 plus 6.5 for boys minus 6.5 for girls. So they will attain their target height. But general population curve pe agar if you plot them, they will be below -2 standard deviation. We call it as familial short stature. There is nothing much you can do except counseling that kid, you are fine, just that your mom and dad's genes have they don't have good height, so you can't have good height. So obviously you don't say it like that. It's just a stupid way to make you remember for your exam. So familial short stature is different from constitutional delaying growth. Few one-liners regarding psychosocial dwarfism. Psychosocial dwarfism is also known as multiple names. It is also called as emotional deprivation dwarfism. It is also called as maternal deprivation, मम्मी का प्यार नहीं मिला, dwarfism. It is also called as hyperphagic. Hyperphagic क्यों? बहुत खाते हैं, they eat a lot. Hyperphagic deprivation related dwarfism. So these are the three terms. Psychosocial dwarfism, it is related to, there is decrease in the circulating IGF-1 levels due to emotional stress in the child, related to neglect, child abuse, overcrowding, poor birth spacing, and poverty. They usually do not show a good response even to growth hormone therapy, but if given tender loving care, love and care, these children tend to show a catch-up growth. It is more of a diagnosis of exclusion, taking into account the social environment of the child. So this is regarding psychosocial dwarfism. Fourth, we have the primordial dwarfism. Primordial dwarfism is related to severe forms of IUGR in utero. So what happens is, due to severe IUGR, there is a overall reduction in the number of cells, and so it predisposes the child to short stature in later life. That is called as primordial dwarfism. Primordial dwarfism can be either non-syndromic, that is simply related to only IUGR, nothing else, or it can be syndromic. The most common syndromic form of primordial dwarfism is a syndrome called as Silver-Russell syndrome, which we have discussed separately. It is also called as Russell-Silver syndrome. They have silvery hair, triangular face, receding chin, short stature, and some mental changes. So that Silver-Russell syndrome is one form of, severe form of primordial dwarfism. Then coming to hormonal causes of short stature in children, remember that among hormonal causes, the most common hormonal cause of short stature in children is actually hypothyroidism. It is not growth hormone. Other causes, they include growth hormone deficiency. It can occur due to Cushing syndrome. It can also occur due to pseudo hypoparathyroidism. These are the common causes of short stature in children. Remember that their growth velocity or height velocity is significantly less They are significantly less, and they show significant delay in bone age compared to chronological age. What it means is chronological age is significantly ahead of bone age. And replacement, the time of replacement determines what will be the eventual overall outcome in these children. Now, what is the management of short stature in case of children? The management can be divided broadly into two parts. You can call it divide into general measures, and there can be specific measures. The general measures will include looking after the nutritional status of the child. Particularly, you will increase the calorie content, increase the protein content of the child. Secondly, there is a role of zinc in short stature. This is important, potential MCQ. According to Nelson, Indian O.P. Ghai as well as Indian Academy of Pediatrics textbook as well as textbook by Dr. Suraj Gupte, they all say at one place or the other that low dose zinc in a dose of 10 milligram per day given for 3 to 6 months has been found to be beneficial in many patients with idiopathic short stature. So many patients benefit from zinc supplementation in a dose of 10 milligram per day. You can use zinc gluconate, zinc acetate, or any zinc carbonate, any form which comes in the market. Now, coming to specific management will relate to treating the cause. If there is a underlying chronic disease, you treat the cause, patient will catch up. CCF patients usually show very good catch up if you treat the CCF, if you surgically repair the underlying conditions like VSD. Secondly, if in case of hormonal therapies, you need to do hormone replacement. So replacement of the hormone, but it needs to be done before irreversible changes have happened. So replacement therapy is needed. And thirdly, in case of delayed presentation or in patients with your dysplasias like achondroplasia, amelias. Amelia hota hai. What is amelia? Absence of limb formation on the affected side, or severely hypoplastic limb on the affected side. Like fibular hypoplasia, tibial hypoplasia, tibial aplasia. In these patients, in case the short stature is present, you can go in for limb lengthening surgeries. They are usually performed in a slightly older child as compared to young child. And limb lengthening surgeries can involve orthopedic procedures like Ilizarro fixator, or they may involve fixators like rail linear fixators. They can be used under orthopedic guidance. This is the overall management of short stature. What is important regarding growth hormone therapy, that we need to go into a bit detail. So growth hormone therapy, as I've told you, it can be useful in multiple conditions, and where everything else has failed, idiopathic short stature, even zinc has failed, you do give a trial of growth hormone therapy. So what are the indications of growth hormone therapy? Very important, already asked in super specialty as well as one of the central institute entrance exam. It has already been asked. The question was, all of the following are indications of growth hormone therapy in a child with short stature except. So you need to remember all the indication. First is growth hormone deficiency, obviously. Second is idiopathic short stature with low growth velocity. Third, patients with Turner syndrome. Fourth, Noonan syndrome. Fifth, Prader-Willi syndrome. Sixth, primordial dwarfism and Russell-Silver syndrome if it fails to show catch-up by 3 years of age. So 1 year, first year mein nahi start karna hai, you need to wait. If the catch-up growth doesn't come by 3 years of age, then you need to start it. Chronic renal failure or chronic renal insufficiency. And then we have SHOX gene mutations. They are a rare type of short stature related homeobox gene mutations which show responsiveness to growth hormone therapy. And finally, we have a rare syndromic form called as Léri-Weill dyschondrosteosis. So these are the indications. Now coming to the dose and regime that we follow for growth hormone therapy. Optimally, it should be started before 11 years of age. However, in certain scenarios, you can use even in older children. The preparation used is recombinant human growth hormone. It is written as RHGH. This is how it is written in Nelson. So recombinant human growth hormone is used. Earlier, bovine and various other animal derived products were used. They used to cause anaphylaxis. There were also incidences of Creutzfeldt-Jakob disease and all these prion diseases getting transmitted. But now that you are using only recombinant forms, so all those risks have gone away. What is the mode of transmission? You don't give it oral, you give it in the form of subcutaneous injections, preferably given at the night time. And what is the dose? Now, dose is important. Two types of doses are mentioned in various textbooks. You need to remember in both forms. Some centers use dose in microgram per kg per day, and some use it in units per kg per day. So if it is mentioned in microgram per kg per day, it is 25 to 50 microgram per kg per day. You start slowly and gradually build it up. In case of units, it is 0.03 to 0.1 units per kg per day. Either this or this, depending upon what option is asked. Please note, the value will vary according to the units which are being used. Monitoring is done by IGF-1 levels, and overall improvement in height is seen in the form of 20 to 30 centimeters. So total kitna effect aata hai? How much is the total effect? It is as high as 20 to 30 centimeters. However, you need to understand that maximum growth occurs in the first year of treatment. In the first year, approximately 50% is achieved. 50% achieved is, that is around 10 to 15 centimeter is gained in the first year. Subsequent years, it is seen that the response tends to diminish. The child only gains around 5 to 6 centimeter per year. It varies according to the child, but maximum benefit is seen in the first year of treatment with growth hormone. Now, what is the criteria to stop growth hormone therapy? When do you have to stop it? You will stop it when the growth rate is less than 2.5 centimeter per year despite optimum dose. Secondly, when the bones have started fusing. If the bone age is more than 14 years in case of girls and more than 16 years in case of boys, that is indication or criteria to stop growth hormone therapy. Both are mentioned in Nelson 21st edition, and they are also mentioned in the standard endocrinology textbooks and 2 review articles. Very prominently mentioned, not given in GHI, not commonly discussed, can be asked in super specialty exam. Side effects of growth hormone therapy. Some of these children can develop pseudotumor cerebri. They can develop gynecomastia. There can be slipped capital, femoral epiphysis, which is a orthopedic condition. There can be scoliosis. If scoliosis is pre-existing, it can even worsen. So worsening of pre-existing scoliosis or development of new scoliosis, both have been described. Diabetes mellitus, only type 2. There is the risk of type 1 is not increased according to Nelson 21st edition. And some of them may develop mild reversible hypothyroidism, which tends to improve if you if you stop or reduce the dose of growth hormone in these children. Now, what is the risk of malignancy? Risk of malignancy. Risk of malignancy, if you look at some of the older textbooks, they say there is a potential risk of malignancy. However, Nelson and most latest review articles, they all agree upon one thing, that the risk of leukemias and solid tumors have not significantly been increased as seen in larger trials and meta trials, although small trials and small case reports do exist. So the risk of malignancy is not significantly increased. However, there is a catch here. If there was a previous malignancy, then the risk of recurrence as well as the risk of second malignancy has been shown to be increased in these patients. So fresh malignancy hoga, that significant risk is not there. But if the child had some pre-malignant condition or there was some previous malignancy, the chance of that malignancy coming back, some tumor cell surviving and causing a relapse, or a second malignancy happening, like you have those retinoblastomas, second malignancy happening, osteosarcomas developing, those kind of second malignancies can develop. I'm not saying in retinoblastoma, but in general solid tumors, it can happen in these patients. And so growth hormone therapy is relatively contraindicated, and cautious decision needs to be taken based upon specific risk factors present in the patient. Then, before we finish the discussion, one extra edge point I like to discuss here. What is Frankfurt plane? Now, Frankfurt plane is a parameter which is used to define, it is used to minimize the errors when calculating the standing height in a child. When we ask a child to stand in a standing position, what should be the position of the neck? If the neck is like this or like this, it is going to cause problems in the child. So we ask the child to make him stand in a Frankfurt plane. What is the Frankfurt plane? Frankfurt plane is a plane which starts, I'll show you the picture. The lower margin of the orbit of the eyes are in line with the external auditory meatus. So this is the line, that is the lower part of orbit should be in line with this, and this should be parallel to the ground and at 90 degrees to the standing person. That is called as Frankfurt plane. To make it more clear, look at this person. In this person, this is the external auditory canal and this is the lower part of orbit. They should be forming a straight line. This is called as the Frankfurt plane. This Frankfurt plane should be parallel to the ground and it should be at a 90 degrees angle with the standing person. And this is where you will keep the that plate for measuring the height in a standing person. So this is the importance of Frankfurt plane. कहाँ use होता है and how do you identify? It is from the lower margin of orbit to in line with the external auditory meatus. Why am I stressing upon it? Because in Nelson 21st edition, if you read at one of the place, they have not mentioned lower margin of orbit, they have mentioned inner canthus of the right eye. They have mentioned canthus of the eye. Canthus of the eye is superior. It is not canthus of the eye that we take, lower margin of the orbit that we take. So it is incorrectly mentioned in Nelson. All the other standard textbooks are in uniform consonance with whatever it is written here. So this is something you should be careful if you are reading only from Nelson. So this finishes exhaustive discussion of short stature in children.